healthcare. Okay, recording in progress. Crucial conversations, racism and healthcare in the Asian, Asian American, Pacific Islander, and South Asian communities. So thank you all for taking the time and spending the evening with us. And we are it's definitely going to be an opportunity to listen deeply and intentionally, but also have opportunities to share information and discuss what we want our future to look like. So first, I'd like to introduce the AIHM members of the BIPOC committee. Just in the last, I would say, a couple of months, we were a task force, but then we became an official committee of the board. So again, I'm Dr. Yvette Miller, one of the co-chairs of the task for the committee. And my day job is I'm Executive Medical Officer for American Red Cross. Dr. Jean Davis is co-chair of the committee. She's an integrative medicine, she's an HIV specialist at the Los Angeles LGBT Center, and she is an AIHM board member. Dr. Scarlett Soriano is an integrative medicine teacher, educational consultant, and also an AIHM board member. Dr. Rachel Adams is medical director of Santa Cruz Integrative Medicine. Dr. Tabitha Parker is executive director of AIHM. I'm going to circle back around to Dr. Rashmi Muller, as she's going to be one of our panelists, and I'll introduce her at that time. Dr. Dashan Mehta is the hippie doctor and on faculty at Harvard Medical School. Saidi Jimenez is membership coordinator and chapter coordinator. And Jessica Parker is the gluten-free glue that keeps this committee and keeps us all together and keeps us functioning. And she is the academic success coordinator for AIHM and the AIHM Fellowship. So now I'm going to introduce the panelists for this evening. Dr. Li Ming Zhao is a licensed acupuncturist and is co-chair of the NCCAOM ASA Acupuncture Medical Cultural Competency Task Force. And she is a former board member and secretary of the American Society of Acupuncturists and current chair of the ASM Conference Committee. Dr. Sally DeCastro is a physician's assistant and graduated from the physician's assistant program at Charles Drew Postgraduate Medical School in 1977 and was born and raised in Stockton, California, and her parents immigrated from the Philippines, and she is an advocate for access to quality healthcare and to removing the barriers that exist for Asian Americans communities' access to care. And our final panelist will be Dr. Rashmi Muller, who is also a member of the AIHM BIPOC committee, is an integrative endocrinologist at UCLA, and is chief of telehealth at the Greater Los Angeles VA. And some of her specialties are, she has pioneered several clinical programs in integrative medicine, and she has published on the use of experiential learning modules to residents about integrative medicine. So thank you all for, again, attending tonight. So I will turn the program over to Dr. Rachel Adams, who will walk us through or guide us through a mind-body practice to help us get grounded and centered for this session. Rachel?
Thank you, Yvette. I wanted to do this in part inspired by a book by Resmaa Menakem called My Grandmother's Hands, where he talks a lot about getting our minds and hearts in alignment before we do work that's meaty, important, emotional, so that we can all be as open and receiving as we can, and all be connected together. And the other thing that I learned from his book is that when we make sounds like an om in meditation or humming, that we actually stimulate the vagus nerve, which calms us down and gets us into that parasympathetic receptive frame of mind. So we're going to do a little bit of that today. I'm going to use some of the Taoist practices that I've learned from the Taoist tradition as well. So I want you to start by getting centered wherever you are with your feet on the floor. If you're sitting or if you're standing, feel your connection to the earth. I want you to put your hands on your belly. I'm going to step back a little bit so you can see me. And I want you to take a deep breath in through your nose and all the way out. Getting present to being here right now. And I want you to rub your belly, preferably in a clockwise motion. And then we're going to go counterclockwise, bringing your body present for this conversation, bringing all of you to it. Another deep breath in through your nose and out. Feeling your body settle in after whatever happened in your day, letting go of whatever you're bringing with you from that experience. And then gently bringing your hands to your heart area and gently rubbing that heart area. And with another deep breath in, we're going to make the sound, the healing sound of the heart in the Taoist tradition, which is haw, like the caw of a bird. Enough of a awe that it vibrates your chest as you make it. And as we make that sound, I want you to imagine that your heart center is beginning to gently soften and open like a rose. So deep breath in through your nose. Imagining that heart beginning to soften and open. Another deep breath in. And imagining as you continue to breathe in and breathe out with that heart sound, that as your heart opens and everyone else's heart opens on this call, that each of us through time and space are connected as that energy moves through you out into the universe and connects all of us in this call. One more time. Now a little shake. And we're ready.
So thank you so much, Rachel, for that invitation for us to get in the same energy and get grounded for this wonderful experience that we're getting ready to have. So I've already introduced the panelists, so they're going to speak in this order. Dr. DeCastro, then Dr. Li Ming Zhao, and then Dr. Rashmi Muller. So Dr. DeCastro, I invite you to take the floor.
Well, I hope everyone can hear me. I just want to introduce myself and let you know that I'm honored to be able to speak on this topic. When I first read about your organization, and I do a lot of research, just basically just updating my own knowledge on what we're speaking to today. But regarding your organization, the Mind-Body Connection, I've been practicing neurology for 20 years. And I've been fortunate to have a boss who truly believes in the mind-body connection, to the point where when he does speak out, he speaks of the IBS, irritable bowel syndrome, but with our patients, it's the irritable brain syndrome. And when he talks about disease, he talks about dis-ease. So when I address your organization, it pleases me to understand this is the population I'm speaking to that are already open to the other aspects of what's really going on with our patients, our communities, with their healthcare, their mental health care out there, and why it's so difficult for us to tap into some of these more difficult cases of disease, pain, mental health, and I'm really glad to be part of this. I'm going to address the fact that, again, I'm first generation Filipino from Stockton, California, which consisted mainly of healthcare work, not healthcare workers, basically farm workers, factory workers, workers in canneries. And that was my life. And we were one of the largest Filipino communities in the United States at one time. So when we talk about Asian American community, it's the API community. So I'll use that term a lot, but it consists of 20 countries. Within these 20 countries, there are a lot of subgroups, and the largest subgroups we're talking about, and it's basically who came to this country first, again, was basically first the Chinese, and then Filipinos, well, Chinese, Japanese, and then followed by the Asian Indians, Filipinos, Koreans, and Vietnamese. Now there's a smaller subgroup that consists of the Pakistanis, Cambodians, Mongs, the Thais, Laotian, and Taiwanese. We know that that the Asian American population is the fastest growing ethnic minority group in our country, mostly due to immigration. Why this is important is because we're still getting a huge influx of immigrants coming to our country, still practicing their beliefs that they bring into this country. So that's why it's very difficult to apply healthcare now, since this is an ever-changing community. Now, we also know that lack of education plays a key role in poverty in the Asian community. We know that communities that had migrated here earlier already speaking English because their countries were colonized by English-speaking countries. And that included the Philippines and India. The Japanese and Chinese populations were the largest populations to arrive in the early 20th centuries. And though many of them only spoke their own native languages, it took another generation for them to learn English and have the advantage of establishing skilled employment in our countries. So it took a long time. And even with my friends' parents, they never spoke English. And again, with this influx of immigrants, we're still seeing a large population. So language is going to be a huge barrier. So keep that in mind. So we know that because of lack of education or access to education correlates with increased poverty. Studies have shown that higher education, the higher income in the subgroups of these API communities, with Asian Indians leading the charge, followed by Filipinos, Japanese, Chinese, and other Asian Indians and Vietnamese and Koreans. So you can already see that with what you see, who has the jobs within our country. But it doesn't necessarily mean that access to healthcare. Okay, what happened was the access to quality healthcare included the following culture factors. So again, access to quality healthcare included the fact that the barriers were low English proficiency. Some languages were difficult to translate to understand medical terminology. Trust in ethnic providers, even within my own culture. You see, again, we wouldn't go to another Asian ethnic group because we didn't trust them. Or so we could see that even within our own Asian community, let alone trusting going outside to a non-Asian provider. Belief in the non-medical causes of their illness. Like I have a cousin who really thinks that her problem is not medical, but it's caused by something else other than medical. So for her to get seek treatment is not realistic. So we have to break those barriers. The barriers and paranoia, modesty. I mean, Asians by general are very modest people. We don't like to be shown in the spotlight. We're very, quote by quote, very stereotypically timid, and we don't like a lot of attention. We don't want to be a burden to our families, and it's a generational stigma for asking for help outside our communities. And the problem with that is that we're underreported. We're not seeking help, and the problem with that leads to the fact that when we talk about crime and hate crimes in this country, we have to look at why we're underreporting and not asking for help, and why we're not trusting in this country. Now, understanding the challenge of past and present barriers in providing quality care in our community is we first have to understand and define what these barriers are. And some of these, and all y'all know this, Asian myths versus facts. Asians are portrayed as thanks to media, as very affluent and educated, and thanks partly to the large percentage of Asians now in our universities and Asians coming across for these high-tech jobs, which makes it look like all Asians are very wealthy since they're driving around their BMWs and living in Silicon Valley, and that is not the case. We're only looking at a very small subgroup of Asian Americans, ignoring the fact that Asian American populations in some of the largest cities have the highest poverty rates. When we look at past national health data and studies on ethnic disparities, they did not include Asian Americans, only Blacks and Hispanics. There's a problem there because we didn't get included in a lot of the research data, which helped to get funding for proper, programs within our communities. Initially, when the Healthcare Insurance Affordable Care Act was developed, it did not include Asian American Islanders. It only focused on non-Hispanic whites, Black, and Hispanics. Eventually, when it did start to include Asian American API community, we're still a small subset of Asian American population that remained uninsured. And part of this had to do with their poverty, their immigration status, which is huge. They didn't know where their status was. How could they get insurance? And competency in the current healthcare system and the language barrier. Now, the one thing that has helped a lot was having an increase of Asian Americans in government positions, which helped awareness of the Asian health population and the healthcare needs in these populations. And having these resources help collect data, which is finally coming out throughout different countries, different parts of our countries and various institutions, public health institutions, which greatly addresses the barriers, the disparities within the API communities and as well as subgroups. Now we have to understand the subgroups of the Asian American communities because each subgroup face higher risk of healthcare, and because of that, we have to address them separately. And there's a myth that Asian Americans are healthy because they're thinner. And that has been a barrier for a lot of professionals because they don't look for those risks in Asians. They don't think about asking about cancer risk and diabetes risk. And we have to know because there's a huge risk factors because we're so diverse. And some of these factors are disproportionately affected our Asian American population, which includes the fact that a lot of Asians still smoke. This is not frowned upon in these countries. And smoking leads to a large part of health diseases, cancers, heart disease, pulmonary issues. You can't tell them to stop smoking. We could try, and we will continue to try, but a lot of commercial is still focused on getting Asian communities to smoke. The mental health screenings and also cancer screening, the lack of knowledge of risk factors have been a big issue in trying to get our Asian American populations to seek help early. We know that there are known risk factors, and the data is out there: heart disease, cancers, hepatitis B, osteoporosis, tuberculosis, neurologic disorders, suicides, mental health, because we underreport. It's a shame to think that we have someone mentally ill. Actually, when I was growing up, I didn't even know one of my friends had a sister who had Down syndrome. They hid her. We never saw her. And this wasn't that long ago. And this is still happening today. So, this kind of shame, these cultural barriers are real out there. And again, we need to address them. And, we'll talk about how they're addressing them now in this country, which is great because the awareness is out there. So be aware of the risk factors.
Sally, I'm going to ask you to just wrap it up in a minute, please.
Okay, real quick. And the most important is understanding these risk factors so that we can help change their lifestyles, make them secure in the medical needs, knowing that there's help out there, and knowing that right now, currently, we have organizations, we have institutions that are addressing these with research and data that we need so that we can go on further. Thank you.
Right. Thank you so much. Thank you so much, Sally.
I know. I learned a lot, and I just had to throw it out there.
I know. I understand. I completely understand. So the next speaker will be Dr. Li Ming Zhao.
Can you see my screens? So thank you so much to the members of the AIHM BIPOC committee for having me for this very important conversation. So throughout my presentation, actually will overlap a little bit with Sally's. I'm first going to share with you the artwork of Amanda Ping Bodhipatia. In response to the increase in anti-Asian discrimination and harassment, the New York City Commission on Human Rights developed a public education initiative as a testament to the beauty and resilience of New York City's Asian Pacific Islander and Black communities. So as Sally said, the AAPI community is not a monolithic group. It represents 23 million members of nearly 50 different ethnicities. And you may have seen the different acronyms for this group, including AANHPI, which is the designation that was signed by President Biden for the celebratory month in May, and APIDA. And the term Desi refers to the people and cultures of the Indian subcontinent and its diaspora, including those who trace their origins in India, Pakistan, and Bangladesh. So now you know who we are. Let's take a look at where we are. The Pew Research provides a breakdown of the largest Asian groups in the United States. And obviously local city level breakdowns are even more important. But this map gives us a very basic idea of the distributions. As practitioners, it's really important that we strive for cultural competence. To be compassionate healers, we must have an understanding of the cultures of our patients and of our communities. So as Sally said, you have heard of the model minority perpetual foreigner myth. To assume that all Asians are silent, wealthy, and smart, a model minority does great injustice to all, especially to those who are disenfranchised by this idea. While I've personally known this as a myth, I must admit that as an Asian American, I've played into this, accepting this role, perhaps because it was easy and safe to be complacent and silent. However, with the rise in anti-Asian sentiment, easy and safe is no longer an option for me. So as a healthcare practitioner, it is important for me to stand up on my soapbox and speak up against this injustice. And now, mind you, you can't tell on Zoom, but I'm really short, so I need a really big soapbox to stand on. Now, this anti-Asian sentiment is not new in America. It was strong in America even before the Page Act of 1875, which basically barred Chinese women from entering the United States because we were thought to be prostitutes. And of course, regarding the wealthy aspect of the model minority myth, as Sally said, I have to tell you, I personally do not know any of those crazy rich Asians. In fact, the income inequality amongst Asians is the largest of any racial group in America, with a tenfold difference between those who are on top and those who are on the bottom, especially when we look at the income breakdown based on ethnicities, so with Southeast Asian groups of the Hmong, Burmese, and Cambodian on the bottom of that spectrum. Income is, of course, one of the great determining factors when it comes to access to insurance and healthcare. So regard to healthcare, it is so imperative that we do not let this model minority myth affect our health outcomes. One of the hot questions, when people ask me where I'm from, I happily reply, Vermont. However, most of the time, they're not interested in that. The question is, where are you really from? So after I ask them where they are from, I do share with them that I'm one of the 57% of the Asian Americans who were born in a different country. I am Chinese American. Regardless of whether one is an immigrant like me or like my cousins who are fourth generation Asian Americans, we are often seen as the perpetual foreigner. To this I reply, Asian Americans are as American as any non-Indigenous groups in the United States. According to the American Association of Medical Colleges, Asians make up 17% of physicians. And so Asian Americans are imperative to the healthcare of America, as well as other aspects of American life. So what can we do about this? How can we support our AAPI community? Perhaps you are 1 in 6 who is Asian. Perhaps you have experienced this discrimination. If so, we are here for you and here to support. For those of you who are in a place of psychological and physical safety, I invite you to join me in speaking up against this Asian discrimination for yourselves, your colleagues, your families, and your patients. to help your patients, we must examine our own cultural competence and cultural humility. Do your own self-reflection. Figure out what your biases are. Being at the intersection of female, Asian American, and an immigrant, I was personally triggered by the Atlanta shootings. Learn about yourself. Figure out what triggers you. About 20 years ago, my friend pointed out this idea of the Asian American model minority myth disparity to me. While she and I are both Asian women who immigrated to the United States around the same time in our childhood, her story as a Cambodian refugee is quite different than mine as an immigrant from Hong Kong. She was born during the Khmer Rouge, at a time in a time of war in a country ravaged by genocide. Southeast Asian refugees, such as my friend, are at risk of post-traumatic stress disorder associated with trauma experienced before and after immigration to the United States. One study found that 70% of Southeast Asian refugees received mental health care or diagnosed with PTSD. It's important to recognize the history of war as related to mental health. In many Asian communities, discussion of mental health is taboo. In 2018, Asians were 60% less likely to receive mental health treatments as compared to non-Hispanic whites, while the overall suicide rate for Asians is actually less than half of non-Hispanic white populations. In 2019, suicide was the leading cause of death for API ages 15 to 24. With the rise in anti-Asian violence and the trauma associated, it's even more imperative that we check in with our AA and HPI communities on their mental health, as well as to see if they feel safe mentally, emotionally, and physically. So just simply listening is important. As Sally said, although language can be an issue with Asian communities, translation services are key. It is so important that we don't rely on children or family as translators. We don't want a situation where a child, even an adult child, while acting as a translator for a medical appointment, learns about their parents' traumatic experiences for the first time. We must listen with compassion. Now, my friend is one of the lucky ones. She is actually an emergency department physician, perhaps using her PTSD experience on a daily basis to help others. She contributes to her Cambodian community by giving talks about COVID safety and healthcare. She's even on the US Disaster Medical Assistance Team to help all those around the world in need of her services. Sadly, she does occasionally treat some of her community who perhaps due to generational trauma, PTSD, have led to situations where her ED assistance is needed within her community due to community violence. Many of us, myself included, are not as amazingly generous and compassionate as she is. However, we can all do our part. Whether it is something as simple as telling our patients about projects such as the Yellow Whistle Project, it's the yellowwhistle.org, which provides whistles for AAPI communities so that they can just simply make some noise if they're in danger, to making systemic hospital changes to ensure patient safety, such as bidirectional safety agreements with patients. We all need to do our part to help. We cannot be silent. So we must stand together in unity to provide inclusive diversity, equity, and access in healthcare so that we can all put an end to all types of racism and discrimination. From Frederick Douglass's opposition to the restrictions of Chinese immigration to the Young Lords and Black Panthers' use of acupuncture in the late 1970s and early 80s to combat heroin addiction, history has shown us that we are stronger together. We can all uplift each other. Yes, I believe in New York City, and more importantly, I believe in our country. So thank you so much for your attention.
All right, thank you so much, Li Ming. We appreciate all that you shared with us. And the last panelist is Dr. Rashmi Muller. Take the floor, Rashmi.
Okay. Thank you all so much for this opportunity. I echo all of the sentiments and knowledge and wisdom shared by our other two panelists, Sally and Dr. Li Ming. Really incredible thoughts and action items that we can take forward. Now, I'm a member of the Indian American community. I immigrated to this country as a child. I was part of that wave of immigration that happened post 1964. So my experiences as an immigrant are far different than the immigrants that came before me, whether they be from other parts of our Asian countries or even other parts of India. Oftentimes, I think, as has been mentioned, we are quick to lump all of our groups together when convenient, but then also to contribute to othering when it seems appropriate, right? To separate ourselves from each other and say, well, that doesn't impact me or this doesn't impact me. And what I appreciate about this group in general and the opportunity to speak tonight is to really talk about the ways in which, especially us in integrative medicine, have the opportunity to change that framework and really move the conversation forward. Now, Dr. Sang really well described what so many of my patients that I take care of that are Asian who have experienced intergenerational trauma from either their immigrant experience or as refugees from certain countries, or just the lasting effects of colonialism, which have ravaged the planet, and we are seeing them now today. And really using the opportunity to really use integrative medicine to find a way to heal that trauma and move forward, giving space to not only hear their stories, but to understand how they recognize and honor spirit in their tradition has been something that I have been fortunate enough in my practice to have the time to bear witness to and to observe, because I do think it takes that time. Just as, you know, I'm from India, I am a practicing Hindu, but certainly, especially when we talk about things like yoga, we tend to have a very biased view, a very, you know, Hindu biased view of this practice, or it's either completely biased in one direction or devoid of discussing the spiritual aspects. And that dichotomy doesn't really serve anybody well, right? Because it leaves out so many of the people who practice these mind-body techniques. We can call it prana, we can call it chi, we can call it vital life force, but we know when we feel it. And I think oftentimes when I think about caring for the Asian community, I think about this dichotomy that I see where so many of these traditions are part of our culture and they're part of our cultural heritage. And at the same time, in modern medicine, they now have evidence behind them, right? So I recommend yoga and mindfulness to my patients with diabetes because there's evidence behind it, and we've run through millions of dollars of medical research to prove something that we all knew was valuable. And I wish we could perhaps take those same resources and serve the community rather than the research industrial complex that has to continue to churn evidence for these practices that we know in our hearts work because we've listened to our communities. You know, I've known to do yoga poses since I was a little girl, right? This is something I learned. Not everyone has that, but certainly we all have our own heritable traditions. And the other part of colonialism is that we tend to divide them into East and West, right? So Western medicine is considered what we practice here, and Eastern medicine is from the East, but that ignores the knowledge and the wisdom that comes from the continents here on this planet that are, you know, also have their own traditions. It ignores all of African medicine. There are so many things that colonialism has done, and what I hope for is that in discussing the ways in which racism infiltrates our society and medicine, we can then break down those barriers and really talk about solutions moving forward. And certainly the first point is, as Dr. Sang mentioned, is to make sure our patients are safe. Are they feeling safe? Just as there was recently a shooting in Atlanta targeting Asian women particularly, there have been multiple shootings also targeting the Sikh community, which is a subset of our Indian population. They are known for wearing turbans and were particularly targeted after 9/11, but have been targeted in this country since they arrived. They arrived in the early or late 1800s as farm workers. So again, they have had years of persecution, and until we all feel safe, it's hard to find a way to move forward. But truthfully, we have to be able to have these conversations like we are now, make space for healing, and honor the ways in which we have contributed to the pain and suffering, and then find a way forward. That's really all I have for tonight. I'm really looking forward to speaking in our panel discussions and in breakout groups to try to discover solutions moving forward. But thank you very much, everyone. I hope that as we break out, each of us can talk about the ways this has shown up in our communities and how we can move forward.
So thank you so much, Roshni. So I want to thank all the panelists for sharing their thoughts and giving us some things to talk about when we go to the breakout sessions. So now I'm going to turn the session over to Tabby to lead us into the breakout sessions.
Great. Thanks everyone for being here. And I really want to thank each of the speakers. Just really wonderful presentations and thoughts and ideas to get us started. So we are going to go into breakout groups, and each of the groups will have a facilitator in that space and kind of go through a process, and then we'll reunite into this bigger group after that process. Just so you all know, we are recording the session and would like to share it with the larger community, but the breakouts do not get recorded. So the breakouts are really a space for us to, just share anything that we wish to share. It's a really safe space. We ask that when we come back, you all kind of decide who will share from that group and what is okay to share. So, we just really want to keep everyone's confidence, make this a really safe space, and also just very generative. So I'll leave it to Jess to just explain a little bit of the logistics of how we get sent off into the rooms, although I am sure most of us are very Zoom savvy by now. So thank you all for being here too.
Yes, thank you so much. It'll be about 30 minutes we have in these small groups. And if you've been shy to be on camera in the bigger group, I hope you're able to join and show your faces if you're capable at that time. And it should automatically bring you back into the main room when we're done. So here you go.
Thank you everyone for the powerful contributions. I know my group just touched me so deeply, and just want to take a moment to think about what this means, the powerful collective harnessing of wisdom and love and positive intention that happens when we gather in this way. So thank you for being present. Thank you for being vulnerable. Thank you for sharing your knowledge and your questions and all of you. And may we continue to engage with each other in this way and manifest shift in every realm that we inhabit. I'm just going to take 1 minute to do a breath with us as another transition to support us to kind of process and allow, simmer in a little bit of what we experience and sort of set the tone for the conversation that we have now in sharing across the groups. This is a near and dear practice from the Institute of Heart Math that I know many of us know and love. And it's a heart breath, a heart lock breath. And so I like to just put my hand, you can see my physical, sort of not my physical heart, but more like my chakra, my what I would say, my spiritual heart, what my center of my chest, but you put it wherever is right for you. And if it's safe and appropriate for you to close your eyes or lower your gaze, then I invite you to do so. And this is a beautiful breath that has been shown to very quickly in their research studies on this to lead to a shift towards greater heart rate variability and greater coherence patterns of heart rate variability when people are being followed as they do this breath with, heart rate variability monitors. And we know that that alone is an independent sort of assessor and predictor of cardiovascular health. So there's 3 steps. The first step to this breath is beginning to imagine that instead of the breath coming into the lungs, it's coming into the heart. So put your heart right here at the center of your chest. You can put your hand there, and as you breathe in, direct the breath into the center of your chest and imagine that it's going into your heart. And as you breathe out, release the breath from the center of your chest. So breathing in again into the center of your chest, filling that beautiful inner space, that inner heart with love, light, whatever you would like, and then releasing that from the center of your chest. And moving on to step 2, I invite you now to keep the awareness at the center of your chest, but now bring forward a positive emotion. A great way to do this is to think of a memory, something you did, an experience you lived that immediately allows you to feel a positive emotion. So for me, it's jumping into the ocean, which I did today, jumping in and feeling the waves and feeling the joy that comes. You find your own positive emotion and allow it to wash over you. And then see if you can put the 2 together. So you're breathing into your chest, into that spiritual or energetic heart, and feeling those waves or whatever your own memory that brings you a positive emotion, and then breathing out. Once more, breathing in and feeling that positive emotion, calling it forward. And if you can't think of something in your past, create one as if it were in the future, and breathing out. We'll do one more breath this way, breathing in and really feeling that moment in your life, that positive emotion, giving yourself permission. Don't hold anything back. Why would you right now? And release. And the third step, which has been shown to be actually, when they do this in groups, to lead to the greatest coherence, as if we were hardwired for compassion, is this third step. I invite you now to add in one more component, and that is, as you're breathing out, to send that positive emotion that you have out to whoever might need it in the world, sending it out to the world. So we'll do 3 breaths this way. So breathing into the center of your chest, remembering something that gives you a positive emotion, feeling some joy, some love, whatever you wish, and then sending it out for whoever might need it as you release your breath. Breathing in and filling your own cup with that joy, with that peace, with whatever it is that you're calling forward, and sending it out. And one last breath. Let's see if we can go out to the whole planet, to all living beings. Breathe in, fill yourself, rejoice, fill your cup, and then just send it out. Thank you. Thank you for being here. And I turn it over to Jean if she's here. I love that. I see this beautiful movement. Oh, I can feel so much love from all of you. And if Jean is here, then Jean, please take it away to lead us into the larger group sharing. Thank you for the hearts. Thank you for the presence.
Thank so much, Scarlett. Thank you very, very much. So what I'd like to do now is call on each one of the groups to let me know who's going to be doing the teach back, provide the information that we covered. I know in Sally D. Castro's group, our person is Amy. So Amy, I'm going to ask you to start off.
I want to thank you for organizing this so we have the opportunity to learn and grow and become more aware and more present. And in our group, one of the things we talked about and that you led us in, Jean, is looking at how we can bring more awareness and authentic presence to those we serve. So an issue came up that was, how can we learn more about the different types of Asian groups and how can this be incorporated into schools? And we had someone from MUIH, which is an acupuncture school in Maryland, who talked about, being able to take the action step of bringing this to the community at that school, because it is impossible for us to provide specific and appropriate information, whether it's diet, whether it's issues around sex or intimacy, without being aware of the cultural presences and challenges for that person. Are they Filipina and Catholic? Are they Muslim? Are they Buddhist? And what does that mean for us? And how can we be culturally sensitive and aware so the recommendations we are making are appropriate for that person in this moment where they are at the age that they are. Gideon, who does work in hospice care, spoke about the imperative of at end of life specifically, and in the challenges in different cultures of families taking ownership of the patient, and the challenge of trying to figure out whether the family was determining what the patient should know, whether they should be aware of a diagnosis that is life-altering, that is at the end of life, because the family's concerned about not having hope and wanting to make sure that this person is at peace. Does that supersede the patient's right to know, and how tricky that can be? And so learning how we can bring that into our practices as well. Some of us work really hard to learn about our patients and find out how we can access them through language without fluency, but with demonstrating presence for our patients by meeting them where they are. And the bigger questions are how, some of the MDs and medical practices, we're looking at how we can incorporate that into, Alex is from MUIH, how we can incorporate that into training so we can bring that into practices, so it's not the odd person who knows about it because it's important to them to meet people, but that we have institutional ways of bringing that awareness to all practitioners, to all providers within the context of that. And I hope I have done justice to the conversations.
You did a great job. Thank you so much, Amy. Thank you. Now, who's going to do the wrap up for Li Ming's group?
I will fill in some of the holes, and I will ask Scarlett to add to it if I'm missing stuff. So because we talked about refugee, the importance of acknowledging the difference between refugee and immigrant status in the United States, and with the trauma, while all groups, there's trauma involved with all groups, the difference between the trauma involved with being a refugee versus an immigrant. And to acknowledge that trauma-informed care is important for all of our patients right now because of the issues that we are all facing, and also as healthcare practitioners that we need to reflect on ourselves. Scarlett says that there's amazing resources available at the Boston Medical Center for refugees specifically, and I don't know if there are other organizations that provide care center, specifically refugees, but it's a wonderful resource. And so if any of you are working with refugee communities, hopefully we could all reach out and be able to have access some of those resources. There have been a bunch of webinars available. And so on recording is also Tufts Medical Center. I think it was through the Boston Globe that they had that information out there. And the resources that they have for anti-Asian violence specifically and equity in healthcare. One of the most important things that we were talking about is self-awareness. So with our cultural competency task force, we have resources for us to figure out, to learn about ourselves. It's really important for us to reflect on our own biases and our own preferences to help us navigate the world. We share some resources such as Hollaback. So ihollaback.org is a wonderful group. They teach the 5 Ds of bystander intervention. If you have not taken their training, please do so. Thank you, Scarlett, for posting the links. So iHollaback, they have trainings for anti-Asian violence. They have LGBT, they have women. I've taken a bunch of their courses. I can't remember a bunch of them, but I do recommend that you go to their website to learn more. And Stop AIPIH, which is actually something I've been watching since probably March of last year, keeping track of the anti-Asian violence that has been going on. We had Mina, who works with the VA, telling us about her experiences with working with the veterans, and also with the idea of COVID and trauma. And Hong works in California, in LA, with 2 different communities, and being able to navigate, to switch from a Latino community to a Japanese community, and being able to navigate the world with different practices, to be able to be culturally competent and to be aware of the cultures of the different communities and the different needs of the different communities. So we were able to discuss many things. Am I missing anything, Scarlett?
That was fantastic, Lee. Thank you. And you jumped right in. You know, we hadn't determined who was going to lead the post group discussion. And thank you for wrapping us up in such an amazing way. Bill Meeker also gave us some really wonderful concrete recommendations about creating learning objectives for interprofessional education that just really weave this type of understanding into the becoming of a health professional as a very important step forward.
Thank you so much, both of you. Rashmeet, who's going to do your wrap up?
So I think Darshan's going to speak.
Okay.
We had an amazing, an awesome discussion, and I think so. Our group sort of shifted. It's interesting how the different groups kind of shifted to different areas, and ours really shifted to thinking about what's the responsibility of the professional body towards building education. And so, Afua, I was thinking from the accrediting body in acupuncture to obviously what's responsibility of AIHM, and then I'm also part of the academic consortium for integrative medicine health. And so, we and I think one of the things that I think one of the ideas we talked about is that how do the professional bodies really agree upon, unite, one, to make a statement that this is a commitment of our organization, and I think second, then also what type of training, and I think it starts even the basic level of just people having vocabulary, as we know that we don't, we use words like, say, cultural competence or cultural humility, or, these are still words that are still very, they're new for a lot of practitioners, and especially integrative health practitioners. It's not part of their curriculum. So I think the professional bodies' responsibilities, like AIHM and others, would be to really create a space for people to, one, have safety in learning, but also then really feel like, okay, I actually got some learning out of it. And that is actually helping me be a better provider to the patients that I serve. So I think that was one large thing. And then how you go about doing that, it comes in different ways. I think one is obviously making, really bold statements, uniting the different bodies, but it could also be, do you create requirements for whether it's through education or licensure, and you advocate for that. And those, I think, are questions that we raised and to be further explored. And then also, what might they even look like? So just as one example was like in our conferences, can we actually create for example, a color-coded approach? This is the cultural humility theme. If you want to attend talks, you know exactly where to go at different parts of our meeting to attend and be, and they could be different. It could be having one could be more research-oriented talk. One could be a much more clinical practice talk. But you can, it's very clearly identified and designated as such. So I will pause there today. And we had very obviously wise people in our group. So I'll stop here and see if I missed anything.
Thank you so much. Thank all of you for being here, participating in this critical conversation. We're going to continue to have critical conversations, and we want you to come back and be part of those critical conversations. My co-chair, Dr. Yvette Miller. Yvette, you want to quickly talk about our upcoming presentations, our upcoming critical conversations? Are you there, Yvette?
You're muted, Yvette.
Okay, did I unmute?
Yes.
You did.
Okay, great. Yeah, I'm like multitasking here, which is a no-no. Well, yeah, so again, as Jean said, thank you all so much for attending tonight. And so we are going forward, all of our conversations that we're going to have is going to have this title as Crucial Conversations. And so some of the ones that we are thinking of and may likely be our next conversation is around generational trauma. But tonight, so many ideas, I'm sure, is floating through everybody's head. That generational trauma one was something that we were thinking about being the next one, but I think probably when we get back together, as a committee, we're going to think of some other things that probably even came out of this session, because that's how we had the topic for some of our other sessions, is what came out of a session that we had previously. So thank you so much for your contributions, your ideas, and for everybody really bringing their true authentic selves to the conversation, because that's what's going to make the changes to the world that we want to be in, is for everybody to have the space to bring their authentic self to it. So I am going to do I'm going to take a little bit of time, really just like 30 seconds that, Scarlett offered to us, to just sort of close up that through heart math, and just make that intention that, tomorrow when we emerge into the world, or later on this evening, because there's people on the West Coast that it's still, early evening for you, just go out and walking to that space of being grateful and being thoughtful, and just letting all of that goodness just sort of roll through every cell of your body. So just quickly, just focus your attention on the heart center. And just again, imagine your breath going in and out through the heart center. And breathe in deeper than before, and breathe out. And I'm also going to bring in some of the work that Rachel gave to us regarding making a sacred sound that will also bring us all together and unify us. So as we inhale, take our final breath in, let's exhale with that deep sound that shakes the body, that makes the body tremble, and that shakes us all into awareness. Breath in. Ah. So thank you so much, everyone.
Thank you. Good night.
Good
Good
night,
night.
everybody.
Bye.
Thank you.
you.